am Prof.Manavalam. Let us see yet another interesting topic in obstetrical nursing, that is oxytocin. It is a continuation of prostaglandin what we have seen in lecture series 1. This oxytocin also we can see through a case study presentation. A 24-year-old Nina was admitted to labor ward with mild pain on the abdomen and lower back. Mild abdomen pain as well as lower back, it is indicating the mother has started a true labor pain. But her gestational age is 40 weeks. It is named as a term. Her obstetrical history is gravida 3, para 2, and she is having 2 alive baby. Previous 2 deliveries are normal vaginal delivery. She doesn't have any previous medical problem. Present pregnancy also uneventful. She admitted to the labor ward, but she doesn't have any progress of labor, but her gestational age is 40 weeks, near to term. So no other way, so we have to induce the labor. For induction of labor, already we seen we are commonly using the dinoprostrone gel for cervical ripening, but mainly for contraction of uterine contraction along with the dinoprostrone gel, we must use the oxytocin. So oxytocin, its primary action is it is acting on the uterine myometrium. So it is contracting the uterine muscle. It is very much helpful for the progress of labor. Along with we are administering the dinoprostrone gel. Next we will move on to the definition of. So oxytocins and whatever prostaglandins, everything is coming under uterotonic tags. It is a chemical component. It is mainly helpful to increase the uterine tone and also the contraction of the smooth muscles of the uterus. During the labor process, naturally, this uterotonic which will be released in the body that cause for uterine contraction and it facilitate the progress of labor. So along with, for some of the mother, this natural uterotonic is not enough to carry out the labor progress. So for this purpose, in order to add to that, we are using the drugs like oxytocin and prostaglandin to enhance the process of labor and ease the delivery process. Types of uterotonics, there is ergometin, prostaglandin and oxytocin. Prostaglandins already we have seen. So now we are going to see about the oxytocin in this. So oxytocin, it is stimulating the oxytocin receptor that is commonly present the uterine muscles. Uterine muscle, at the same time it is also increasing the prostaglandin release, that is it is also stimulating the prostaglandin receptor that is also presenting in the lower uterine segment. So not only it is stimulating the oxytocin receptor to release the oxytocin, it is also stimulating the prostaglandin. So the same way, it is not only inducing the uterine contraction, it is also helpful for the some part of it is helpful for the cervical ripening also. Next move on to the ergometin. It is mainly increasing the intracellular calcium release. It causes for myometrial contraction. The classification of uterotonic. In order to remember the uterotonic in a simple way, they have given a mnemonic that is mom can't do. So it expands like M stands for methogen, O stands for oxytocin, M stands for misoprostol, C stands for carboprest, D stands for dinoprostol. In this we have seen about the misoprostol, carboprest, dinoprostol in previous lecture series. Now we are going to see about the oxytocin in this. Oxytocin is one of the hormone that is mainly, it is natural hormone produced by the posterior pituitary gland. It is one type of natural uterotonic. There are another one uterotonic drug also there, that is called as a pitocin. It is a synthetic form of oxytocin. We will see what is the difference between this natural and the synthetic form of uterotonics. First one is oxytocin. It is a natural hormone made by a woman's body during the childbirth process that produce frequent, strong, lengthy uterine contraction. Next move on to the pitocin. It is a synthetic form of oxytocin. It is often administered by IV. It is mainly to accelerate the uterine uterine contraction during the labor process along with natural hormone. If we are administering the synthetic form of oxytocin, means it is helpful to accelerate further, it is helpful for the progress of labor. There are the oxytocin we are using in a different forms. Take example, it is used in the form of synthesized, pitocin, stimulation. First we will see about the synthesized. It is coming in the form of 5 units per ml in a ampule. One ampule, it is one ampule, it consists of 5 units of synthesized. It may be used as a controlled infusion. So they are taking the synthesized mixed with either oral or NS. This is the IV fluids, and they are putting into the controlled infusion. So they are using the syringe form for this infusion process. Next, pitocin, it is coming in the form of 10 units per ml in an ampule. It consists of 0.5 ml. Next, move on to the symptometry. It is a combination of syntocin and 5 units, syntocin and 5 units, and ergometrin 500 micrograms. So it is a combination of syntocin and ergometrin. Next, move on to the indication of using oxytocin. So indication, it may vary during the pregnancy, labor and postpartum period. 3 different period of time we are using the oxytocin. For during the time of pregnancy, we are commonly using to induce the abortion. In case of high daddy for more ectopic pregnancy, to expel out the product of conception, we are using the oxytocin. For oxytocin challenge test, in order to know the fetal reassuring status, we are doing the challenge test. For that, we are administering the oxytocin. To stop the postpartum bleeding after the evacuation process, we are using the oxytocin during antenatal period. Next, move on to the labor. For induction and augmentation of labor, we are using the oxytocin. In case of uterine inertia, uterine is not contracting, in the absence of uterine contraction is present, means in order to stimulate the uterine contraction, we are using the oxytocin. To prevent and treat the postpartum hemorrhage, again the muscular contraction is very much, contraction and retraction is very much essential to control the postpartum bleeding. For that purpose, oxytocin we are using. In case of treatment of atonic means absence of or less uterine contraction is there, that leads to postpartum hemorrhage, means in that condition we are using the oxytocin. During the postpartum, to initiate the let down reflex, that in case of breast engorgement or normal let down reflex of the breast, for this we are using the oxytocin. It is naturally occurring oxytocin that is produced by the posterior pituitary gland, that is initiate this process. If it is not, means we can administer the oxytocin. For promotion of the uterine involution, the oxytocin is very much essential. Next, contraindication. So it is mainly acting on the muscles that is present all over the body. During the time of labor, it is acting on the myometrial muscles. During the time of pregnancy, we should not administer for grand multipara mother, because already their muscles lost their power. It is because they underwent too many deliveries. In case of contracted pelvis or cephalopelvic disproportion, there may be a disproportion between the fetal head and the female pelvis. In that condition, if you are administered, means it leads to hyperstimulation. There is chance of uterine rupture. Previous history of LSS and hysterectomy, we should not. Malpresentation, which should not, because the normal delivery process is not that much possible in this condition. Next, during the time of labor, all contraindication, whatever we seen during the time of pregnancy, it is also contraindicated during the time of labor. In case of obstetrical labor, that is commonly happening when the muscle lose its power, or the fetus it is bigger in size, means there is a higher chance of obstetrical labor. That time we should not use the oxytocin to increase the uterine contraction. In case of non-reassuring fetal status, in coordinate uterine action between the upper and lower uterine segment, it doesn't act harmoniously, means we should not administer the oxytocin. Apart from that, at any time, any period of time, if mother in the state of hypovolemic or any mother is having cardiac diseases, we should not administer the oxytocin. Next, what may be the side effects to the mother by administering the oxytocin? It leads to hyperstimulation. More than 3 contractions that may occur during 10 minutes period of time means it is indicating hyperstimulation. If further leads to uterine rupture, hypotension, water intoxication that is happening because of administration of oxytocin, hypertension and myocardial infarction also that may occur because of administration of oxytocin. Side effects to the fetal distress may occur, fetal asphyxia because of fetal death and increased incidence of neonatal jaundice because of some changes that occur. If the uterus is hyperstimulated means it is automatically give the compression over the umbilical cord as well as the placenta. So automatically the blood supply which will be getting reduced to the fetus. So the fetus end up with distress asphyxia, fetal death. Next, how we can administer the oxytocin. So initially we have to start with a low dose because we should not start with a higher dose. It may cause for uterine hyperstimulation and uterine rupture. So in order to avoid all those complications, we have to start with a low dose. It starts from 1 to 2 units per minute and we have to increase gradually. We can escalate the dosage every 20 to 30 minutes by 1 to 2 milli international units. Up to maximum we can increase 8 milli international units per minute. And during the time of administration we have to continuously monitor the uterine contraction. The mother is experiencing 3 uterine contraction in 10 minutes period of time. It is lasting more than 40 seconds means we have to maintain the oxytocin in maintenance dose. Sometimes we can use as a intramuscular injection, but most of the time for induction of labor we are using as a controlled intravenous infusion. We are taking the oxytocin and mix up with either oral or NS and we are setting the drop rate of 15 drops per minute and later we are increasing or escalating the dosages. So while administering the oxytocin as a nurse, what are the responsibility we have to possess in the sense always we have to assess the patient intake output chart because what I said as a side effect there is a chance of water intoxication that should be avoided and it should be monitored. Uterine contraction should be monitored by putting the mother under cardiotocography monitoring and continuously we have to check it out by monitoring the photograph. We are plotting the photograph, through that we can know the uterine contraction and maternal vital signs also we can plot it in the photograph. FHR and everything we are plotting in the photograph. We have to administer the injection by IV infusion. We have to evaluate the length and duration of each contraction. If we have to notify if any abnormalities is present in case of the contraction, each contraction it is lasting over 1 minute time period or absence of contraction in both the thing, we have to immediately inform to the obstetrician. And we have to teach the family and the patient to report in case of increased blood loss, abdominal cramps and increased temperature. We are continuously be with the patient, be with the mother and monitor. In sometimes in absence of us we have to inform to the mother as well as the family members to report all these undue things. So this is how we have to administer and manage the mother while mother under oxytocin drip. I hope everyone understand very well about the oxytocin.